Good evening. Tonight we're going to be chatting about all things lipid, ApoB, tools and tricks of the trade. So this will be kind of an overview for people who've worked with me in the office, where I go through their 8-page handout over Cleveland Heart Lab or Boston Heart Labs to review their advanced lipid profiles. But for those that haven't seen this before, this is the intro to how to read your own lipid profile. So welcome everybody who's joined me tonight. This is the makeup for last night. Tonight's going to be all about ApoB. And if you see me in the office, you always see me carrying a tennis ball around when I explain lipoproteins, because you need to understand what a lipoprotein is, and sometimes I can explain it better when there's actual visual. So what is cholesterol? It's a waxy, fatty compound that is vital for health and life. Without cholesterol, you're dead. But cholesterol is like oil and vinegar. It will not float in your blood, like oil and vinegar. So it needs something to carry it or ferry it around the system. Now, glucose can dissolve in the blood and be carried around without a carrier, but fats cannot. So the body will make lipoproteins, lipid protein carriers. So the lipids are on the inside, the proteins are on the outside. Think of it like a cargo ship. The liver makes these things. So what goes inside? Cholesterol goes inside. Those are building blocks to sex hormones, bile acids, cell membranes. You need cholesterol. Without cholesterol, you're dead. But some of the major benefits of the lipoproteins, or I should say major functions, is to deliver triglycerides. Triglycerides are energy. For the most part, all your cells can make all the cholesterol that they need. Sometimes the adrenals need some support, but not every cell, or definitely not every cell, can make its own energy supply. So when you eat foods, it gets broken down into, energy into your mitochondria. The lipoproteins are ferrying around the triglycerides, which are an energy form that can be used in your muscles, for example. So cholesterol goes inside, triglycerides go inside. There's phospholipids, which are just building blocks for the cells, and then the fat-soluble vitamins, A, D, E, and K. Those also go inside this. So the liver makes them, pumps them out, sends them through the blood vessels. Then, let's say a muscle cell needs something, it will bind to the ApoB protein that's on the outside of the cellular particle. The ApoB protein is essentially the white stripe on the tennis ball. Binds to it, downloads it, takes out what it needs, repackages it up, sends it out. Now it's back in the bloodstream. So it's going through and it has to get an off-ramp. The off-ramp is often the LDL receptor on the liver. It's like a catcher's mitt. So this comes through, gets in there, pulled back in the liver. The liver breaks it down, puts the cholesterol into your intestines, and it's to be eliminated. But it's typically one of these three places where if somebody's going to have dyslipidemia or abnormal lipid profiles, things go awry. Either their body's making too many of these lipoproteins. Second, they don't make enough LDL receptors, or the LDL receptors aren't staying out long enough to clear the blood of the lipoproteins. Or three, it's an issue where the cholesterol is basically being aggressively recycled in the intestine. There's like a bouncer that basically opens the door and says, come on back. So the cholesterol goes right back to the portal circulation to the liver. The liver then makes more lipoproteins, wraps it up, sends it back around the journey again. So either using the Cleveland Heart Labs or the Boston Heart Labs, you can usually get an idea of which way that is going to be having an issue. It's too many of them produce, not enough LDL receptors, or it's having an issue with hyperabsorption. I should press that. It's actually only Boston Heart that actually has that cholesterol balance test. So if you really have a lipid issue, the Boston Heart test really is the gold standard right now for that. Cleveland's still a great panel to have. They have better inflammatory markers, also some better endothelial function markers. So I use both interchangeably, but if I'm really concerned about lipids, I tend to favor more Boston Heart. So that's how you kind of first want to think about what is cholesterol and what is a lipoprotein. So when you get a lab report, what do you look at? So on the traditional cholesterol panel, which is basically in my mind ancient technology, it's not really great at predicting risk. So your total cholesterol is almost a meaningless number for most people. It's not the cholesterol that's the problem, it's the lipoproteins that carry the cholesterol around that is the problem. So cholesterol, total cholesterol numbers can be measured in milligrams per deciliter. If your total cholesterol is over 300 milligrams per deciliter, you possibly have familial hyperlipidemia, which is a genetic abnormality, 1 in 250 people has this. You're just going to have naturally high cholesterol from basically birth on. And we'll talk about that in a minute, why that can be a problem. But if your total cholesterol is over 300, that's a check mark. What's going on with the genetics, or have they made a recent major dietary change, switched up to keto diet, had normal cholesterol before, and now their total cholesterol is 300-400. The LDL cholesterol, same thing. It really doesn't predict risk well. The LDL-C and the LDL-P can be concordant or discordant, and it's often more discordant in people who are insulin resistant. Discordance means that you can have a normal LDL-C but a high LDL particle count. And it's more about the particles going through your system than it is the cholesterol that's inside of it. So I will look at the LDL cholesterol, and it was over 190. Again, it points towards FH, or familial hyperlipidemia, but I don't necessarily treat the LDL-C. I will look at the triglycerides and the HDL-C as markers of your insulin sensitivity. Are you likely to be pre-diabetic or diabetic? But even that is somewhat of a false metric. It's just a rough idea that, how do they handle their glucose disposal? There's other markers to look at other than that. So a traditional lipid panel can sort of tell you that you're on the right track if it's stone cold normal, but if it's high, it really doesn't tell you much. So you want to get an advanced lipid profile test. And that's typically done through either Cleveland Heart Lab or Boston Heart Diagnostics. Those are the two main labs that do it. There's others. You can get them done through LabCorp. Quest has a Cardio-IQ, similar panel. Vibrant America also has some ways to check ApoB. So there's other companies, but Cleveland Heart Lab and Boston Heart are really kind of the two workhorses for the advanced cardiovascular testing. But on advanced lipid testing, you're going to see something called the LDL particle count. Think of that as the number of cargo ships that the liver makes. Different labs have different cutoffs, but a rough estimate is, if you have plaque in your arteries, you generally want that number less than 1,000. Second metric will be is the size of the LDL particles. It used to be a bigger idea to think that the small ones are more risky. Not necessarily. I learned that at one point, the type A's were like a tennis ball, and the type B's are like a golf ball, and that your arteries are a tennis net, where the big fluffy LDLs are not going through, but the little small dense ones, easier to get through. That really doesn't play out as much as they really looked into it. It's more the total particle count that was concerning, and just tends to go with it. If you have a lot of the small dense ones, you have a lot of the particle count anyway. But if you have a lot of small LDL particles, maybe a marker of insulin resistance, or it's a genetic abnormality. The smaller ones do tend to stick around in the system longer. It has a higher residence time, and it may get oxidized. If it gets oxidized, then it's more likely to get retained in the artery wall and proceed to build up more plaque in the arteries. So that's the total LDL particle count, and then the small LDL particle count. The HDL particles are not as useful as a predictor of risk. The HDL functionality is much more important than know your total number of HDL. There's not a great test for looking at your HDL functionality. HDL has 200-300 different jobs in the body, essentially. One of them is to do reverse cholesterol transport, basically go inside the intimal space, grab onto any cholesterol that's in there, and get it out of the artery wall and take it back to the liver to recycle it. But HDL is also very important for the immune system. So you don't know where your HDL is going and what it's exactly doing. So a blood level of HDL-C is not a super useful metric. If it's super low, maybe that increases the cardiovascular disease, but again, tests don't guess. So look at the health of their arteries with carotid scans, CIMTs, CT coronary calcium scores, or clearly CT angiograms. Those will tell you, that person has plaque, then having a low HDL probably is a problem. But the converse is if you have a really high HDL-C or high HDL-P, can be a marker of inflammation, damaging the HDL particles, and essentially think of them as like, rusted cars. You got to replace them. So the liver has to make another HDL particle to replace the things that are getting damaged. So you have higher and higher HDL particles, and you think that you're heart attack proof because you have high HDL particles, but that's not necessarily the case. That inflammation makes these HDLs actually more atherogenic. They can start damaging the arteries fairly significantly. The best test that you can look at for that is myeloperoxidase, or MPO. It's available from both of the major cardiovascular labs. But if you have high myeloperoxidase, very likely have low HDL functionality. So then you can only really focus on lowering inflammation and working on lowering the LDL particles. We won't get too much into the VLDLs or the IDLs tonight. They're not as big of a issue for most people. And if you have an issue with that, you can assess that with the blood test. But the other thing we'd want to look at on the particle counts is if you have LP little a, which 20% of the population has, should check at one time. The reason you want to check LP little a is that if your LDL-C is elevated and you're taking any type of lipid-lowering therapies and it's not, quote, going down, it's probably because the LDL-C is being miscounted as an LPA particle. The LPA particle is very similar to an LDL particle, but it has a little protein on the outside of it called a kringle. The longer those kringles, the less of them you make, but the kringles can interact with the endothelial glycocalyx, that gel coat that lines your arteries. If you damage that gel coat, you're set up to developing more plaque. And on the outside of the LDL particles, that also have the protein that makes it an LPA particle. That ApoB protein is there. So you probably have heard some of the other podcasters and such talking about apolipoprotein B or ApoB being a better predictor of risk than maybe even the LDL particle. That is true in ways because it encompasses all the atherogenic type of particles, including the IDLs, the VLDLs, but those are usually very small in most people. The lion's share of the ApoB particles are going to be the LDL particles, probably about 90% of them. So if you only have the LDL particle, it's not the end of the world that they don't have the ApoB, but if you don't have the LDL particle, the ApoB is probably the best metric to be following going forward. But the ApoB, again, is just the protein that is a structural protein, keeps it into a sphere, but it also acts like a key, so that when this is flowing through the blood, the body can bind to that protein and pull it out of circulation. Those ApoBs are on the outside of the LDL particles and the LPA particles. Since there's not great effective treatment for LPA, and it's a major risk factor for early cardiovascular disease, you have to work on lowering ApoB through the LDL pathway. So this is where treatment options come in. Is it an issue of hyperproduction? Okay, that's where statins, fibrates, fish oil, niacin, bergamot, red yeast rice, that's where that works. Is it more an issue with the LDL receptor, which is not a great test to actually assess the function of the LDL receptor. You just have to kind of infer by other metrics. But this is where things like berberine can potentially help a little bit. It's a very, very weak oral PCSK9 inhibitor. Sometimes it's good to synergistically use with statins to help clear the lipoproteins. That's one of the ways the statins actually work, is that you'd lower cholesterol production in the liver makes less particles, the liver still needs things, the liver will express more LDL receptors, and you clear more effectively. So berberine can keep the receptors out a little bit longer, and this is the mechanism of action for the injectable PCSK9 inhibitors. So Repatha and Praluent are the brand names for those. They're injectables that are monoclonal antibodies that essentially affect an enzyme called PCSK9. When you inhibit that enzyme, you keep the LDL receptor out longer. That enzyme will normally degrade the base of the receptor and basically think of it like a catcher's mitt, that falls over. If you can keep that catcher's mitt out longer, then you can clear more of those ApoB particles. And then the third thing is that if the person's a hyperabsorber of sterols, which you can assess on the Boston Heart Diagnostic Panel, the cholesterol balance test, ezetimibe, or used to be brand name Zetia. There's only one dose of it, it's 10 milligrams once a day. It blocks that gate from opening up and the cholesterol from coming back into the portal circulation. So some people who have an issue with having, quote, normal lipids, and then they go on a keto diet, or kind of a higher fat carnivore type diet, and their lipids go through the roof, it's often an issue with that hyperabsorption in the intestines. So if they're not willing or don't want to change their diet, then ezetimibe is probably the only option at really reducing their lipoproteins. I know there's some kind of myth out there that cholesterol doesn't matter in atherosclerosis. That's completely a myth, but it doesn't mean that if you have high cholesterol that you automatically are statin deficient. You have to figure out why the lipids are abnormal and treat the root cause of it. Use the right tool for the right job. So ezetimibe can work in that instance. So those are things I wanted to share with you guys tonight. Is my thinking off the top of my head of how I address the lipid abnormalities for the patients that come in and work with me here at Apollo Cardiology. It's more complicated than high cholesterol is always bad, and a total panel, or total cholesterol, an LDL cholesterol, an HDL cholesterol, and triglyceride. Unless you have familial hyperlipidemia, really isn't going to point you in the right direction. Are you at high risk of a heart attack or not? Unfortunately, half the people who have heart attacks and show up in the hospital had, quote, normal cholesterol. don't currently round in hospitals because I want to focus on the prevention of heart attacks, but I've treated hundreds if not thousands of heart attacks in my career. Unfortunately, in the hospital, didn't have access to this advanced testing. So in my old days when I would round in the hospital with somebody with a heart attack, we take care of the acute emergency, get them on the right cocktail medications at that point that kind of starts putting the fire out. And then when they were stable as an outpatient, then we would start the root cause analysis, the deep dive to figure out why did they end up in the hospital with a heart attack. My goal now is to prevent people from ever showing up in the hospital with an event. And it always will start with an advanced blood work panel, but you also need to test, not guess, what is your arteries doing with that information floating through your blood? Because not everybody necessarily needs aggressive medications. So that is what I'll probably talk about next week. In the poll, I had it listed as lipids, ApoB, and then also best test to evaluate your subclinical atherosclerosis. That came in as a close second. So that's what we'll do next week, Monday, 6 p.m. Central Time. We'll do a talk on what are the best non-invasive tests to look at your current healthy artery. There's Thomas Syntham, a physician from the 1600s, who had a saying, "A man is as old as his arteries." So I will teach you what tests to get if you don't already know what those tests are. I've learned from some good business mentors that the job of a good educator is not to keep saying new things to old people who followed me before. So it should be good that if you've heard me say this before, I should be saying old things to new people. So if you're new, welcome. Thank you for watching tonight. If you haven't watched much of my content, I have hours and hours of videos on dyslipidemia, subclinical atherosclerosis, endothelial dysfunction, erectile dysfunction, a lot of biohacking talks, photobiomodulation, blue light blockers. So if there's a topic that I haven't hit in my feed in the past, or there's a new topic you want me to hit and it's in my wheelhouse, send me a comment, send me a direct message, and I'll happy to try to do that. But next Monday, 6 p.m. Central Time, we'll do a chat about the best non-invasive test to look at the health of your arteries. So I'll quickly look through here and see if you guys have any questions for me. If you do, I'll try to answer them, and then I'll let you guys get on with your evening. So somebody's saying, can you have normal cholesterol and still have plaque buildup if you have high blood pressure? So definitely yes, you can. Cholesterol will always be inside a plaque, and you don't necessarily need to have super high levels for that to happen. You will have to have endothelial dysfunction, which starts with damage to the endothelial glycocalyx. There will be an inflammatory cascade where basically the body thinks a bacteria or virus is invading the artery, and the immune system ramps up. Different interleukin cytokines, get upregulated, and then your body uses basically monocytes that became macrophages, and they gobble up any cholesterol that gets into the arterial wall, and then basically a pimple starts building on the artery wall. It's that pimple that's full of damaged cholesterol and the markers of the immune system that eventually can rupture the blood clots, and that's what causes a heart attack. High blood pressure often is the sign that there's evidence of endothelial dysfunction and lower nitric oxide levels. So somebody's asking, what is the test for hyperabsorption of sterols? That is the cholesterol balance test. The basic company that does this the best right now is Boston Heart Diagnostics. Also Mayo Clinic, I don't know how exactly you can get that as a normal person, but they also do a fairly comprehensive steroid absorption test, but Boston Heart is probably the best for it at this point. All right, so somebody's asking, can one prevent oxidation? So let's start with, what are you trying to do from a lipid standpoint? You want to prevent the LDL proteins on the outside of it from oxidizing. If it's oxidized, it's been modified and damaged. It's that modified damaged cholesterol particle that's much more likely to get retained in the artery wall because your body thinks it's a bacteria and starts gobbling the stuff up. But oxidation is essentially rusting. So we're all breathing oxygen, breaking down our foodstuffs into energy. This is not the only way, but think of your mitochondria as an engine, and you break down the foods, your carbohydrates, your fats. You have to burn that stuff for energy, and you're going to use oxygen to do that in most cases. If you have really healthy engines, you burn that fuel very cleanly. If you have very leaky engines, you have spread apart, let's say respiratory proteins, and you're not efficient at making energy, there's going to be basically smoke that leaks out. It's reactive oxygen species that's leaking out, and that ROS can damage the lipid membranes around the mitochondria. So it's an issue mostly with weakened or not energy efficient mitochondria that's contributing to a lot of the oxidative stress. All right, somebody's asking, can beta blockers, specifically nebivolol, which used to be known as Bistolic, raise triglycerides? The person's read mixed reviews online. I've not personally seen significant rises in triglycerides from beta blockade. I would imagine that probably the mechanism of action would be that probably at higher doses, the beta blockers can maybe affect some glucose metabolism, and then you're going to package up them in triglycerides if you don't have your muscles being heavily utilized with resistance training, basically sucking that glucose in for energy. Thank you. Somebody already called my office today and wants to start working with us. That's awesome. Thank you. Cassidy is working really hard right now to get to all your guys' requests. It's a good problem for us is that more and more of you guys are finding our way of treating people at more of a root cause, a more exciting way to than just throwing medications at people. We actually get to the root cause of why you have elevated lipids, why you have atherosclerosis. So thank you for reaching out to us. If you are interested in working with us, we still are accepting patients. We don't have a onerous application process at this time, but maybe we're getting there. So if you are interested in working with us at Apollo Cardiology, we're located in St. Louis, Missouri. You can go to my website. It's drtwyman.com. Our contact info is there. Best to either send us a text message or email, and then we will get back to you about the logistics of how you can work with our office. All right. So somebody is asking about, once the arteries are damaged, is there anything you can do to fix it? What do I think about ozone? So you have 60,000 miles of arteries. The first sign of arterial damage is endothelial dysfunction, and that's predicated by having endothelial glycocalyx damage or EGX damage. So first, find out what is the offending agents if possible and withdraw those. So if it's high blood pressure, if it's inflammation, oxidative stress, high ApoB, start working on those things. But yes, there are numerous lifestyle metrics that can be modified. So your sun exposure, your exercise, your nutrition, those things will have an effect on improving the endothelial glycocalyx. There are particular targeted nutraceuticals that can have an effect on boosting nitric oxide production. And there's definitely pharmacological agents that have an effect. The ACE inhibitors, the statins all have an effect on it as well. And what do I think about ozone? It depends on what is the use case for it. For arterial damage, no, I don't think there's any great benefit for ozone. If you have a chronic infection, Lyme disease per se, ozone might be beneficial. But you have to be careful. Ozone is not a panacea. It's not magical. There's different ways to receive ozone. It could be insufflation, where it's put through the rectum and absorbed through the GI system. It can be done through IV, where they mix your blood in it. That's usually 10 passes one way they can do it. But you have to work with somebody who knows what they're doing with it. The way ozone probably actually works is that it makes your body make more antioxidants against that quick pulse of ozone. And then your body helps lower inflammation, oxidative stress with that. So it's kind of more hormetic. But if you have really weak mitochondria that are already kind of leaking a lot of smoke, there's a lot of oxidative stress, throwing on more oxygen into the system just makes the process even more inefficient. You're making more reactive oxygen species. So you got to be really careful with ozone. If you have really weak mitochondria, you have to go really slow and work with somebody who knows what they're doing with it. All right. So if somebody's interested in working with us at Apollo Cardiology, we have a couple different ways to work with us. So best to speak to Cassidy at the office to go through the pricing structure and such. Well, thank you for the kind words, guys, tonight. And then somebody said they just found me on my YouTube video with Mind Body. Yeah, if you haven't seen that one, that was actually one of my better podcasts because I was able to go kind of both ways, talking about the subclinical atherosclerosis, endothelial dysfunction, but I also was able to talk about heart rate variability, talking about photobiomodulation, definitely a deep dive into circadian rhythm management. So kind of encapsulates kind of my philosophy of how I treat my patients. So if you're interested, MindBody just released it, I believe just yesterday. It was actually pretty funny as I was scrolling through my Google News feed yesterday, and my face popped up in my feed. I've not actually seen myself pop up in my Google News feed before. And I had some friends from high school texting me as well that popped up in their feed. So if you follow me online, I did put in my stories yesterday. Maybe I'll just repost it tonight for those that didn't have a chance to see the story yesterday. If you're on my email list, I'm going to send out an email this week that has links to any of the recent podcasts I have done. So if you want to go deeper into some of these topics, those are going to be more targeted for that. But I will share the link to the Mind Body one as well. And somebody's asking, do I recommend an on-site visit? For the majority of patients, yes, I would recommend an on-site visit because multiple things can be accomplished on an on-site visit. We have non-invasive tests that can tell you what's going on with your arteries. Next week I'll go deeper into the science behind them, but basically the max pulse looks at arterial elasticity. If you have elastic arteries, you have healthy arteries. If you have a normal central aortic blood pressure, then you truly have normal blood pressure and you do not have hypertension. What is your carotid age, your CIMP age, I should say? Do you have soft plaque in the arteries? We also have a device that looks at endothelial function called the EndoPAC. So it tells us how much nitric oxide your body can produce. So we have that all in one space in epicardiology, and I think that's probably the best way for most people to truly know what's going on with their system is to have an on-site visit. Somebody's asking about arrhythmias. Not necessarily my area of expertise, but arrhythmias are just abnormal heart rhythms. It's one of those things where you need a 12-lead EKG. You probably need a Holter monitor or an event monitor to catch what's going on, and then that kind of guides you to what's probably the driver of the arrhythmia. Sometimes it's electrolytes, low potassium, low magnesium. Sometimes it's thyroid dysfunction, either overactive or underactive thyroid, inflammation, oxidative stress, all can drive arrhythmias. The other big one is non-native EMF, Wi-Fi, Bluetooth. The closer those things are to your body, the more likely the heart is to have arrhythmias. Somebody's saying that they had a high heart rate a couple months ago, then it suddenly disappeared. Could it be long haul COVID or Lyme myocarditis? Would not be able to know without a physical exam, blood work, and EKG to know if that was truly the case. In all comers, people who've had COVID, heart rhythm issues are more common. I believe atrial fibrillation is somewhere in the neighborhood of 4 times more common after a COVID infection. So not uncommon for people to have palpitations, fasting, or higher resting heart rates, or palpitations after COVID. So again, it's one of those test don't guess scenarios. You need blood work to figure out how much inflammation is present, if any. Electrocardiogram to see if the heart's electrically normal. Maybe you need a heart monitor. And if you're going to rule out myocarditis, you need at least a baseline echocardiogram or ultrasound of the heart. Maybe even need a cardiac MRI with gadolinium to see if there's any scar tissue in the heart. And somebody put in a question tonight: what are your top things to do to have a healthy heart in the menopause stage? So I did do a talk more about women's health a few months ago, but the basic is that women's number one cause of death is heart disease, just like men, but it tends to be about 10 years later than men, probably because of the cardioprotective effects of estrogen. Estrogen helps the endothelial glycocalyx stay healthier. It is also something that tends to have a beneficial effect on the HDL function as well as the LDL receptor. I believe that's the main way that it helps the LDL particles be less. And then when estrogen declines in menopause, The LDL cholesterol tends to rise, the HDL tends to lower. So it's the basics. It's optimizing nutrition by getting enough protein for your muscle mass, carbohydrates based off your glucose tolerance. Maybe you're going to want to do a continuous glucose monitor to figure out what your carb tolerance is. Your fat profile is going to be based off what is your resting metabolic rate and what calories you truly need. And then you can do cholesterol balance testing with either Boston Heart, or I'd actually say it's a fatty acid balance testing with either Boston Heart or Cleveland Heart. That can tell you essentially how well you're absorbing the different fats in your diet. So do you need to consider, cutting back on saturated fats? If you have trans fats, which you shouldn't have, avoiding those things. Then you can fine tune your exercise, stress management, sleep. All those things have to be optimized for longevity purposes. So somebody's saying soft plaque versus calcified plaque. Even with the zero calcification score, you can still have soft plaque. Absolutely. I'll go more depth next week when I'm going through these non-invasive tests. But that's the name of the game, is finding out what stage somebody's in. It starts first with endothelial dysfunction. The arteries get impaired at releasing nitric oxide. Things start sticking to the arteries. The arteries get inflamed. Certain layers swell. Then the soft plaque starts building up. Then the body keeps trying to take care of this plaque problem by scarring it down. And at the end of that process, calcifications will occur. So if you do a CT coronary calcium score, your calcium score test should be 0 under the age of 40. If you're above the age of 80, it's very unlikely your score is 0, but I've seen it. So it's more benefit for the people between 40 and 80 for the most part. But a calcium score of 0 does not indicate for sure you do not have plaque in your arteries. It takes some time for sometimes the plaque to calcify. So the carotid intermedial thickness test can see if you have soft plaque. There are certain CT angiograms that you can do that can also assess for soft plaque. So somebody's asking, do I recommend hormone replacement therapy during menopause? So I don't personally prescribe it, but it will depend on the person's circumstances. I don't necessarily recommend estrogen replacement therapy just for cardiovascular benefits. It typically has to be somebody who has significant perimenopausal or menopausal symptoms, mostly the vasomotor symptoms. So night sweats, they start having issues with endothelial dysfunction. That's probably how the withdrawal estrogen works, is that it starts having vasospasms in the smaller blood vessels. So if somebody's really bothered by the night sweats, then hormone replacement therapy is a good option for those people, but it's typically best when it's used right to replace somebody as the levels are going down. If you've been menopausal for 20 years and now you're going to start HRT, it's probably not going to benefit you very much, or nearly as much as somebody who's getting replaced right at the beginning. So you have to work with somebody who knows what they're doing with that as well. For the most part, tend to recommend certain providers that I've worked with for many years here in St. Louis. All right, guys, so it's the bottom of the hour. Usually go about half an hour for those that are new. Every Monday night, 6 p.m. Tonight, I know it's Tuesday night, had to reschedule. Was traveling from Mexico City the other day and just had to get some more work done at work and just didn't get to the IG Live in time due to patient care concerns. But thank you guys for your time and attention tonight. Next Monday, 6 p.m. Central Time, we'll be chatting about the non-invasive testing to look at endothelial health and do you have any plaque in your arteries. So have a great week. If you guys need anything, drop me something in the comments or call us at the office in Cassie. I'd be happy to chat with you as well. Thanks, guys.